Hello, everyone. Thank you all very much for coming. It's my pleasure to welcome you to our webinar series, What to Expect, a Guide to Prostate Cancer. My name is David James. I am the Head of Patient Projects at Prostate Cancer Research. Now, this webinar series is a collaborative project between ourselves and the pharmaceutical company Ipsen. So today we have the sixth in our webinar series, and this one today is metastatic prostate cancer, part 1. And we'll have next week the second part to this, metastatic prostate cancer, part 2. Now, we're joined today by 3 wonderful speakers, consultant urological surgeon Phil Cornford and clinical nurse specialists Shievon Smith and Michelle Greenwood. So as I mentioned, this webinar is the 6th of our 8-part series and the first of 2 webinars on metastatic prostate cancer. So today we're going to look at the treatment options available, potential side effects and how to manage them. And then next week, we're going to explore this topic in even more depth, as well as looking at what the future may hold in terms of possible treatment options. And then in our final webinar of the series, we're going to be talking about prostate cancer and end-of-life care, including the emotional, spiritual, and mental aspects of end-of-life care and the planning it may require. And just a reminder, if you have missed any of our previous webinars, please don't worry, as these can all be watched on demand on our website. And that's pcr.org.uk/what-to-expect. And they'll be available on our website. This one will be available on our website about 1 week from today. Now, just a reminder, for the purposes of today's presentation and for simplicity, we've used the term men throughout, but this should be considered to include not only men, but also trans women, non-binary people who are assigned male at birth, and some intersex people as well, as they're also all affected by prostate cancer. So it's my pleasure now to hand over to our first speaker, Professor Philip Cornford.
Hi, I'm Phil Cornford. I'm a urologist from Liverpool, and today we're going to talk about metastatic hormone-sensitive prostate cancer. What is metastatic prostate cancer? Metastatic prostate cancer is a tumor that has spread from its original site and is now growing somewhere else. And we're going to talk about the treatment options and how we'll manage it. In particular, we're going to think about hormone treatments. The prostate grows with testosterone, and testosterone is the male sex hormone. Because prostate cancer cells started in the prostate, they're also hormone or testosterone sensitive, which means that if we reduce or remove testosterone, we will see the tumors shrink and undergo a process of cell death. It doesn't completely destroy a cancer, but it will reduce it for a period. Now, testosterone production is controlled by the brain. The testosterone itself is produced in the testicle, but there's a hormone released from the pituitary gland, which sits at the base of the brain, which drives testosterone production. And as a consequence, hormone therapies can either block testosterone as it works locally, or they can block testosterone production by blocking the release of these hormones from the base of the brain. So what are the treatment options for metastatic hormone-sensitive prostate cancer? Largely, there are 3 different types of what we think of as androgen deprivation therapy. That's really just removal of androgens from your body. we can use a LHRH analog, which is what's blocking the production of the hormones from the base of the brain, or we can use a medicine that blocks testosterone directly, preventing its effect on cells. Of course, it is possible to remove the testicles or the hormone producing part of the testicles, something called an orchidectomy. And historically, that was perhaps the most common way of managing metastatic hormone-sensitive prostate cancer. These days, although it remains an option, it's not used anything like as frequently, and we're not going to talk about that any further. The LHRH analogues switch off testosterone production. It's normally given as an injection, initially started in hospital, but frequently maintained by your general practitioner closer to home. Anti-androgen medicines don't stop testosterone production, but instead block the testosterone's effect on the body. They are commonly used at the time of the first LHRH analog to stop something called a flare. That is a rise in testosterone, which can happen. And more these days, novel anti-androgens are used because they're more effective, the suppression of the testosterone, the more likely we are to have an effect on the cancer. Some patients have been offered chemotherapy at the time of their hormone therapy. Chemotherapy is a treatment that aims to kill or slow the growth of cancers, and it's often given as an intravenous infusion. It will affect normal cells as well as cancerous cells, but normal cells are better able to cope with the toxicity and to repair. It is possible that it will be given alongside both a androgen deprivation therapy and a novel anti-androgen, although it is also true that for many men, it's reserved for when people are no longer responding to hormone treatment. It's a complicated decision to understand what is best for you, and it's important that you talk to the oncologist that is looking after you about what is the best treatment and how the combination might work. So what about the side effects, particularly of the hormone treatment? How will this affect you? I think the most important thing is to understand what will happen. You have lived with testosterone as a normal part of how your body works since you went through puberty, age 13 or 14. Clearly, blocking testosterone will have an effect. It will actually interfere, give you some side effects. The different treatments have slightly different side effects. And you should talk about it with your doctor before you start treatment. Remember, not just your doctor, but the specialist nurses and the rest of the support staff are there to help you and to minimize and manage the side effects of your treatment. To Testosterone, which is a sex hormone, as you might imagine, is mainly involved in sex. It gives you the drive. When you're a little boy, you don't think about sex because you have much lower levels of testosterone. When you go through puberty, it's difficult to think about anything else other than sex, at least for a little bit, until you get used to the effects that testosterone has on your brain. But if we remove the testosterone, you will lose some of that interest in sex. It also makes it more difficult to get an erection, and there may be some change in the growth of facial and body hair. But testosterone does more than that. It affects muscle development and bone strength. And it also gives you some of the drive. And people notice changes in that too. It affects how you feel. Many people notice a change in their emotions, as well as the physical side effects. A change in mood, less drive, and feeling slightly more irritable and sometimes tearful than usual. Because it affects sex drive and libido, you might need support if you still want to be sexually active. And because the desire for sex is a combination of the hormones that you have and your memory of it, this may still be the case. You may notice that the testicle shrinks, and you will nearly certainly notice some change in your body shape. There is a tendency, if you don't do anything about it, to put on weight, particularly around the middle, and to lose muscle mass, particularly from the limbs. And then bone health. Testosterone is an important part of why you keep bone strength. Men have stronger bones than women because of the effects of testosterone. And when you remove the testosterone, men's bones tend to thin over time. And this is something that will need to be monitored and for which you may need treatment. If you have metastatic prostate cancer, it's likely that you will need hormone treatment for the rest of your life, which is why it's important to work at minimizing the side effects of treatment. This slide just shows all those things that we've talked about, including one or two other things like trouble sleeping and memory problems. If you have a female partner, you may be aware that when ladies go through the menopause, when they lose their sex hormone, there is also some of these changes occur for them. It's not surprising, you will also experience some of this. Because living with prostate cancer is likely to have an impact on your emotional well-being and your physical health, we need to work with support groups that will help you not only for the physical side effects, but also for some of the emotional needs that you will experience. And you can see on the slide a number of groups that might help you. It's really important that you talk to the specialist nurses in clinic, because they may have local resources. And certainly in Liverpool, we would have support from clinical psychologists who would also be able to help you if this is a real problem for you. Remember, your experience of the side effects will be unique for you. Everybody feels it slightly differently. Some people have fairly few side effects. I think most people have hot flushes, but again, with time, some patients that becomes something they are used to. However, if you don't ask for support, we won't know that you need it. And it's important that you take the opportunity to get the support that's available. There is lots of help and support to deal with the side effects across the different range of treatments. And remember that both your physical and emotional well-being matter, and you will be listened to and supported so that you get the best quality life that is possible whilst you're on this treatment. Thank you very much for listening.
Thank you very much for that, Professor Cornford. I'd now like to invite our two clinical nurse specialists to take over from here. Over to you, Shiv and Michelle.
Thank you very much, David. So we're going to have a closer look at sexual dysfunction, which is associated with prostate cancer hormone treatment. Next slide, please. So we're going to carry on the theme, and we're just going to pick up some points there about erections and change to your ejaculations and orgasms, really. So obviously, if you've had some treatment, those things are going to change. You might not have any semen come out. You might have a little bit of urine come out. This was something that was picked up on the discussions last week, and I'm afraid that we didn't get round to that question in the Q&A session because I talked too much and overrun. So ways you can deal with that, really, are making sure you limit your fluids, try and maybe wear a condom to catch any sort of leaks that might obviously arise with arousal erections. And then arousal incontinence, I should say. I've got erections on the brain. And in the worst case scenario, you can always be referred for surgery. I appreciate that for many people don't want to go for another surgery, but obviously that can be quite an embarrassing issue to have. Dry orgasm is quite common with our patients as well that have had vasectomy. The most common problem that men on hormone treatment have is that they just, really find it very difficult to have an erection, and that's because of the hormone therapy that we're giving them to, either reduce or block the testosterone. What the way of managing that is that people should be offered medication PDE5 such as sildenafil, which is otherwise known as Viagra or Cialis. I think that obviously we know that this doesn't always happen, and that sometimes doctors are reluctant to give these medications to people. There are other things which Shiv probably knows more about than I do, things like injections into the penis and pellets and creams. And one of the other things that we've talked about recently as well is the pumps. But pumps and injections and pellets and creams are really kind of like, intrusive into your spontaneity of making love and having sex. So I think that those things they're there, but they're difficult. And one of the things that Shiv and I were talking about during the first presentation is that it's not always very easy to access help with those things. So there are erectile dysfunction clinics, but actually getting appointments in those and finding them, because not every place has an erectile dysfunction clinic. So actually getting those access to those services is actually quite difficult, I'd suggest.
We're very pleased as well to see our friend Tammy online, and Tammy was sort of the instigator really of some discussions over Facebook and Twitter. So if you are on Twitter, we are on there as well, so you can message us. Obviously we're not giving personal medical advice, but we will try and point you to the right directions. See your colleagues in the clinic, ask your specialist nurses or your oncologist or even urologists who might be treating some of our hormone sensitive patients to refer you to the pump clinic. It might sound fiddly, it might be a little bit of a different way that you have to engage your sex life. You might need your partner to help you and assist you, but these things are really, really important. And like Michelle said, if you don't ask and explore things, you're never going to know if you'd wish to try it. Now, injections sound really horrible and invasive and distressing. Actually, it's a very small injection that you give into the side of your penis. It isn't as bad as it sounds, which I'm sure everybody online just went in horror there when I said that, but it is actually quite a very easy injection to do, and it really sort of does the trick. I think more the problem is, as we picked up last week, is about the actual libido of wanting it. The actual sex drive is not there. And we had a bit of a discussion, and I talked too much as usual about being there with your partner, touching, kissing, masturbation, and all of those sorts of things too. Can we turn to the next slide, please? Thank you.
So this was also what we talked about last week, is about the fact that it's actually just very difficult to even initiate a conversation about sex sometimes, and some people feel that that's really difficult for them to talk to, especially if you've got a nurse who's probably a lady, because most nurses are. So, you know, if you're a gentleman who are having issues with libido and sex and may not always want to talk about it to a nurse, but like Shiv said as well, if we don't talk about it, then no one can sort of point you in the right direction or give you that help and support and guidance that you might need. So the help and support is there, but actually one of the big barriers is just asking about it and saying, you know, I'm actually having a problem here, which we kind of know you are. So we're quite proactive in our clinics about asking people about sexual function, because when you do ask, the floodgates open, and quite often people have kind of come to see you many times and not raised it as an issue at all. So I think that's one of the things that's quite difficult.
Absolutely, and obviously it's not only a sex organ, as we touched on, you know, previously, because this is an organ that men obviously use to urinate. Penile shrinkage, which is caused by treatments, either surgery, you know, obviously the hormones themselves by nature of how they work, then that adds to lower urinary tract symptoms and, you know, obviously issues with maybe passing urine for some people, not for everybody. So please, you know, don't panic about that, but do speak to your team. Myself and Michelle were talking about sex therapists and, you know, relationship counsellors and things like that. Unfortunately, large areas of the NHS don't actually fund this. So this is really a bit of a postcode lottery, and we're really banging the bell for men like Prostate Cancer Research and Prostate Cancer UK are doing. So please, please ask for these things, because the more people that are asking for these things, you know, hopefully the more it's going to come on board and be funded. And actually, this is a nice guidance. This is part of your cancer treatment, is to deal with your sexual dysfunction, which obviously is limited to pumps and the PDE5s, as Michelle said. Next slide, please. Thank you. Can you move on to the next slide, please?
So hot flushes are another common side effect of hormone therapy. They can be quite debilitating when they happen, especially if you're out and about and it suddenly comes over you and you get so, you know, it can range in time from just a few seconds to quite some considerable amount of time. And, you know, if you're out, it's embarrassing because maybe you get so wet with sweat that your clothes need changing. You get a little bit kind of, you know, confused and a bit dazed with it, because obviously this is really quite overcoming. And, you know, it's difficult. And I think some people just think, oh, well, you know, it's a side effect of hormone therapy. This is going to happen. I just have to put up with it. But there are some things that we can do. We can give you some medication to manage hot flushes. And that can really make a huge difference to people, actually.
So there are things that can help you. And as it says on the slide there, we do recommend that people have less spicy things, use those cooling sprays, you know, sleep in nice cottony clothes. And I've just got to roll it out there and say, actually, I'm there with you. You know, I'm having a bit of a hormonal meltdown, and it is really debilitating, and it does make your mind fuzzy and things like that. So, you know, let people know what's going on for you if you can, and you feel comfortable to do that, because that is actually a really good way to get people to help and support you. You know, we have little fans at work and things like that as well, which we find quite helpful. Next slide, please. So I think the next slide might be going on to the breast, is it?
How about bones?
Oh, bones.
Yes. So obviously hormone reduction, you know, is bad for your bones. So obviously people who are on long-term hormone therapies do have some problems with bones. And obviously that puts you at higher risk of osteoporosis type fractures and broken bones, as like the older ladies tend to get. So you do normally get regular bone scans to check on the bone density when you're on these treatments, and you may be offered some bone strengthening medications, as we call them, if there is a concern about your bones and your bone health.
I think that most patients should be offered biphosphonates if they have metastatic prostate cancer. We know obviously the bones are at risk, but again, as Michelle's saying, that actually varies from centre to centre because it depends how that consultant likes to work. So, you know, other things that can be used for the bone strength as well, you know, bone protection, is actually radiotherapy. So if an area is particularly painful, can give the radiotherapy to treat a bony area and shrink that bony lesion down. And then that will obviously offer the bone some protection and recovery. And then obviously with the bone strengthening drugs that Michelle's mentioned, that obviously can aid, you know, bone marrow recovery. Unfortunately, with any type of cancer, sometimes there is sort of scarring on the bones, and you might hear your consultants talking to you about that. So eating healthy, balanced diets, lots of nuts, leafy vegetables, all of your folic acid, your vitamin-enriched cereals is very, very important to you. And although it says on the slide about your healthcare team will give you, you know, advice, I get a lot of questions about, you know, should I eat these tomatoes? Should I do this? Should I? The amount of vegetables, certain things that you would have to consume isn't really, you know, the answer really, because you'd be eating tons of tomatoes. So we really say have a balanced diet. Obviously, if you like things like yogurt, milk, your cheese, your dairy, which we know is obviously high in calcium, then that's really good as well. And obviously you can have calcium added to your prescriptions as well as a supplement. Next slide, please. So here's the breast area, because I think there was a question that came in a little while ago, and I apologise that we're a bit slow. So as you can see on the screen here, obviously any treatment that's suppressing the testosterone is going to lead to an imbalance in your body. Ladies have a bit of testosterone, men have a bit of estrogen, so we're all a bit of each other really. So as part of these treatments continue, we would use different types of androgen blockade, as Professor was speaking about previously. So in the clinics, we used to use radiotherapy just to the breast buds to stop them being so, you know, painful and tender, because obviously changing your hormones obviously changes how you are, might make you put a bit of weight on, breast tenderness, etc., along with all of the mindfulness angle.
I've not seen it used regularly or kind of as a standard radiotherapy to the chest, but I suppose that again it might depend on consultants and where you are.
Next slide, please. I've never seen anybody have surgery. I just saw that on the end of the slide there. So fatigue is a really big one, and it's always very hard. And especially when you say to people, well, you know, get active, get out, get your running done. I know that Tony would tell me all about the 5K movement, which I'm probably saying it wrong, and he does a lot of exercise. He's amazing. It really helps you, and the reason why is because it makes you feel tired at the right time, so that you'll go to bed, have a restful sleep, rather than having fits and starts in the day. So some people that are really struggling with their fatigue will have a sleep in the afternoon, won't they, Michelle?
They will, yeah. I think when your motivation is low, your fatigue levels are high. When your fatigue levels are high, your motivation is low. So I think it's a bit of a vicious circle. But you know, if you do some exercise, even like a short walk, etc., that actually can boost your energy levels for some time. And then, as you've said, then you might sleep better in the evening if you've done a bit of exercise, or you know, kind of like moving around a bit more, walking, etc., during the day, swimming, things like that. You know, all of those things are a little bit of exercise. Fatigue is very difficult to manage, and it is a bit of a vicious circle, I'd suggest.
So obviously on the slide it's saying don't go driving when you're feeling tired, but you probably don't do that anyway.
Yeah. Okay, next slide, please. So emotional well-being is also difficult. Obviously, we've talked about the impact that the hormone therapy has on your emotions, your physical, fitness, everything really. So it is really difficult to look after your emotional well-being when your body isn't feeling like as it did or as you kind of want it to. There are, ways that we can help people to manage it in terms of psychological support and things like that. But again, it's about how you're managing all of the issues that you're having. If you're having a breast tenderness, how do we manage it? How do we get support? If you're having, most people will be having erectile dysfunction. So it's about how we manage it and how you seek support for that, I'd say.
I think the thing is, it's very tricky, isn't it? Because you've got a cancer where you've obviously got men, and men don't always talk about their feelings, and then suddenly you've given these tablets and medications, and then the next thing you're crying and you don't know why, and it's very distressing. But actually reaching out can really be helpful. Yeah, all right, it's a bit embarrassing when you're talking about erections. It was embarrassing for us the first time. Can you imagine, young girls, even though the hair's white, I'm only 46, but can you imagine the first time that somebody comes to you and speaks to you about their sex life and what they need to do about it? I've been a nurse for 20 years and Michelle, not long after me. So we've been doing this a long while. So you sort of get a little bit blasé about it, and you can see we laugh and joke and have a rapport with our patients. And some clinical staff maybe are not that jovial or maybe encouraging to come forward. But once you come forward and raise that question, you will really get a lot of support. You can obviously get support in various groups. Prostate Cancer UK run a lot of Facebook pages and things like that. Obviously, you've got all of these great resources on prostate cancer research. You have the Orchid Male Cancer, who has videos on their website too. There are lots of places you can go to. What I'd suggest is you go to the right locations to get that support, and reach out, just say something, speak to your family. If you don't want to speak to your family or your friends, then take that outside to maybe an online counselling service where you can speak freely and gain some advice. Obviously, you've got things like Samaritans, you've got mindfulness apps, you've got lots of places that you can get support from. Next slide, please. Thank you.
So in summary, tonight's webinar has been about how when prostate cancer has spread beyond the prostate and is metastasized, it can still remain hormone sensitive, and that is the case. We do see a lot of patients in that situation. It does still rely on testosterone to keep growing, so that's why we suppress the testosterone in the hope that we can keep that cancer under control for a longer period of time.
Your next talk that's coming up next week, they'll talk about patients that haven't got hormone-sensitive disease, where the treatment obviously needs to be changed, but there's still many treatments, and we want you to go away today knowing that there are other treatments. So we obviously use hormone therapies, we use chemotherapies. Up here at St Bart's, we use oral chemo, we use androgen and estradiol deprivation, we use a lot of steroids. And this is obviously research that's been done here at the Institute, and different areas use different treatments naturally, but there are many that are standard of care, and there's many that are coming out now frontline for hormone sensitive disease, which is really, really exciting. So, please take this as positives from these sessions today, because I appreciate from your questionnaire earlier that there was a lot of concern and worry about, metastatic or advanced, whichever you prefer to call it, prostate cancer. So obviously all of these treatments are going to slow the cancer down, and they can shrink it down on scans that you might have, but unfortunately it's not going to cure the cancer. So these cells will continue to progress, and obviously PSA will rise, the prostate specific antigen, and then a different treatment line may need to be started. Sorry, I can't get my words today, can I? So obviously, any side effects should be discussed with you while you're in the clinic before you start treatment, and you should be offered support with sexual dysfunction, which sometimes unfortunately hasn't been done. I would like to think it's done here, but who knows, it could be some of our patients that have said that, so we all think that we could do better too.
And I think that the key is to make the most from your clinical nurse specialist, who will have all the information and know where to get the support from that you need. So I think that's a really important thing to remember, and to know that your clinical nurse specialist will listen to you as well as your oncologist, and to raise these points, because unless, you know, I think we're all guilty of it. If sometimes we're busy, we don't realize that maybe we haven't discussed that with you before, or we don't know that it's bothering you. So you have to tell us, and you know, if you don't tell your treating team, then you're much less likely, obviously, to get support and help that you need.
And I think that if you feel maybe a little bit rushed by the doctors when you are in your treatment session, do go out and find the nurse, and just ask them, because they will support you absolutely. You know, you're physically and emotionally, spiritually, you know, whichever you need.